Hello and good afternoon and a warm welcome to today's webinar. My name is Paul Tingle and I'm the Product Manager for Learning at Skills for Health, and I'll be hosting today's event, Safe Practice in Diabetes Care Delivery. Today we will be joined by Debbie Hicks and June James, co-chairs and nurse consultants from Trend Diabetes, who will be talking to us today about this topic. At Skills for Health, we are very excited to be able to offer the Insulin Safety Getting It Right course as part of our extensive content portfolio. The importance of this has never been more important, and I look forward to hearing Debbie and June share their insights into insulin error in both hospital and the community, and the importance of promoting safety when providing diabetes care for people with diabetes. Before we begin, I would just like to run through some housekeeping so you know how to participate in today's event. I'm sure we are all now very familiar with how Zoom webinars run, but just in case, here are a couple of quick points for you. At any point during the webinar, you'll have the opportunity to submit your questions to us. To do so, just type your question into the Q&A feed at the bottom of the control panel. You can upvote the questions that resonate with you the most. As time allows, we will address as many questions as we can during the Q&A session at the end of the webinar. Any questions we can't answer today, we will reply to you after the webinar. We'd like this webinar to be as two-way as possible. As usual in these webinars, attendee speakers will be muted. So the way to do this is for you to add any comments for us into the chat function. Again, the button's at the bottom of the page. It'd be great if you're willing to just pop your name, role and current location into the chat so we all know who else is on the webinar. And I see some people are already saying some friendly hellos. Shortly, I'll be handing over to June James, co-chair of Trend Diabetes and a nurse consultant in diabetes for the University Hospitals of Leicester NHS Trust and for the Leicester Diabetes Centre. June is an honorary associate professor for the University of Leicester and in her clinical role cares for people with diabetes and advanced kidney disease. She works on various multidisciplinary committees such as the Joint British Diabetes Societies in the development of national guidelines. June is an associated editor for Practical Diabetes and writes in peer reviews for other diabetes journals, including Diabetic Medicine. After June, we will be hearing from June's fellow co-chair of Trend Diabetes, Debbie Hicks. Debbie also is a nurse consultant and has been working in diabetes nursing since 1990, where she developed the Diabetes Specialty Nursing Service in Hull. She now works for Medicus Health Partners with a population of 95,000 patients on their register, leading on diabetes care. She is also on the editorial board of the Diabetes Times and the chair of Injection Technique Matters, Best Practice in Diabetes Nursing, which aims to improve outcomes for people with diabetes who inject. You are in very safe hands with June and Debbie, so it is now my pleasure to hand over to them. So, June.
Hello, and thank you all for joining us today. It's really exciting to have so many on this webinar, and we're expecting a few more as well. So I'm going to talk to you about insulin safety and how we get it right. And I'm going to give you a little bit of background about how we've come to write this e-learning and a little bit of information about what's included in the module. So let's look at the global background. So it's actually 100 years since the development of insulin, so it's really exciting. So if Benton and Best and Colliper MacLeod hadn't done their work, most people with type 1 diabetes would still have a life expectancy of about 18 months. So, and people with type 2 diabetes wouldn't have this amazing drug either. So it really was a well-merited Nobel Prize for the organisers and for the developers that allowed us to use insulin. But equally, it's one of the most high-risk medications worldwide, and insulin error is really common. So the Quality Care Commission and NHS England state that healthcare professionals who handle, so that's anybody who handles it if you get it out of the fridge, prescribe or administer insulin, need to receive regular training and demonstrate competence. So it needs to be used in people who are trained. So how common is insulin used in the UK? Well, there's 3.9 million people in the UK who are known to have diabetes. There's about 1.1 million who don't even know they've got it. 92% of people with diabetes in this country will have type 2 diabetes, but many of those individuals require insulin treatment, as well as other non-insulin therapies. 8% will have type 1 diabetes. Now, these individuals have to have insulin for life. They can't go a day without it. So it's interesting to note that if you look at that whole nearly 4 million, up to 30% of all of those people are actually insulin treated. So it's very commonly used. And between the years of 1991 and 2010, insulin use trebled. And that was in line with the increasing numbers of people diagnosed with type 2 diabetes. So who needs insulin therapies? Well, all people, as I've already stated, with type 1 diabetes have to have insulin to live. It can't just be given for a few weeks and stopped or doses missed. So type 1 diabetes is autoimmune in origin, and there's no endogenous insulin, so no insulin is produced within the body. But equally, many individuals with type 2 diabetes also need insulin. And these are often people that were treated initially with diet, and then maybe diet and some other oral diabetes treatments, but their beta cell function becomes worse the longer they have diabetes, and they may need to take insulin once or more times a day to get their diabetes control in the correct range. So in type 2 diabetes, the body still produces some insulin, but these individuals are insulin resistant, and they're particularly insulin resistant if their glycemic control is poor, they don't take all their medications, if there's an infection or an illness. So the rates of insulin use during this COVID epidemic has really, really increased. It's massive. And people who are having surgery or a fasted procedure. So let's think about national error. So insulin is one of the top 3 high-risk medications, and they don't collect data in the UK on a regular basis. But the National Reporting and Learning System, which used to be called the NPSA, did do an audit between 2003 and 2009 and looked at over 16,000 incidents. And you can see at that time there were 6 deaths. There were 12 incidents involving severe harm and over 1,000 causing moderate harm. Now, as I say, there's no new data relating to this. And when I've talked to the National Reporting and Learning System, they tell me that it's so common and it's not that unusual. They don't produce the facts or the data for us at the moment. But each year there's a national diabetes inpatient audit, at least there has been up until now. It's actually mainly been discontinued. But that told us that in 2017, insulin error occurred in 40% of people with type 1 diabetes and 37% in those with type 2 when cared for in the hospital inpatient setting. It's important that all insulin errors are reported, or else we won't be able to measure any numbers. So if you think about errors, and I just want to go back a minute to that previous slide. I talked about 6 deaths. There's been more deaths than that. And last year, as Debbie and I were meeting for our annual general meeting, a report of another death came. And it was a gentleman that had had an overdose of insulin in the hospital setting. And it prompted us to make this e-learning. Because if we really want to reduce error and reduce harm and reduce deaths, it's important that anybody who handles insulin, so that's healthcare assistant up to consultant, medic or nurse, all need to be trained. So let's see what these errors look like. So they're divided into 3 types. So prescribing errors where the insulin is written incorrectly, how the insulin is given, so the delivery device error, or a dispensing error where somebody's not sure which insulin's been prescribed, but they still give some insulin to the person on prescription. So here's some of the prescribing errors, and the most common for many years has been this using of this prefix of a U. So you either write a U or an IU after the number of units. So if you write a 4 and then put a U afterwards, thinking that means units, that's led to 10-fold overdoses of insulin and deaths, because the person reading the prescription might think it's 40 and not for you. So the use of that U, instead of putting the whole word units, was actually prohibited by Act of Parliament many, many, many years ago. And it's that Act of Parliament is still in situ, but this error still happens. Prescribing the wrong insulin, and that can be seen in handwritten prescriptions and even when using electronic systems. So there might be a drop-down box where all the insulins are shown. The individual doesn't know the difference between an insulin, say Humulin I and Humulin S, and it gives the wrong one. Transcribing an insulin prescription to a new medication chart is a common error. Prescribing when you're transferring to a new ward, or if you're in the community setting, when somebody goes from one nursing home to another, and not prescribing correctly in the inpatient setting when somebody's transferred from an intravenous insulin regimen to a subcutaneous one. So if we look at delivery and administration errors, and this is happened in 2 of the cases outlined by the National Patient Safety Agency. It was using a non-insulin specific device, so an ordinary 2 ml or 10 ml syringe, not an insulin syringe, and then giving massive overdoses of insulin. Drawing insulin from a pre-filled pen or cartridge using a syringe, whether that's an insulin syringe or not. So each pen is calibrated to deliver exactly the right amount when you turn up the dial that gives the insulin dose. If you draw that out of that pen using a syringe, whether it's an insulin one or not, you are putting people at risk. And if you're using a higher concentration insulin and drawing up using a syringe, you may very well overdose them because you're giving them double or triple the strength of insulin. Poor injection technique, and injection technique is really important. If the injections are going into muscle, people will suffer from very low blood glucoses really quickly, or if there's a buildup of something called lipohypertrophy, where the skin is actually damaged, the insulin will not absorb properly. And withdrawing the pen needle before all the insulin's actually been administered means people don't get the whole dose. And I was just talking to you a little bit about lipohypertrophy. This is where these sort of fatty lumps of old insulin sit underneath the skin. It's really important to choose the correct injection site. And Trend Diabetes have made a whole series of resources about this. And they're shown on our website and they're downloadable for free. But it's very important to use a simple rotation process. Other things that are important are to change the needle each time. Don't use one needle on a pen for a week or even for a second injection. And to choose the site correctly and rotate within each section. And you should change that section on a weekly basis. And let's think about dispensing errors. And I've seen this when I was a community diabetes specialist nurse, where a child had gone home on a fast-acting insulin and a long-acting insulin, and they were given the incorrect insulin from the community pharmacist at that time. And because I was visiting the child, because you do if you just put a small child on insulin, within the next 24 hours, I picked it up. So it's things like that. So you dispense or substitute the insulin that's been prescribed to a different one. And as insulins have, there's over 30 different ones, all different names, it's not that difficult to do that. And it's important that the individual who's collecting the insulin, receiving the insulin, knows which one's the correct one. So people should have an insulin safety card, so they can look at the picture on that card and know they're getting the right insulin. So it's essential when insulin is prescribed that it's given for the right person, that it's the right insulin. They all have different actions, and you might take insulin 4 times a day or once a day. That the insulin's in the right concentration, because they make 100 units per mil, 200 units per mil, and 300 units per mil now. That the dose is correct, and it's written to be given at the right time. So if you give an insulin that needs to be given with food, when there's no food that's going to be eaten, there could be a resulting hypoglycemia, for example. And when the prescription's written, it should say the device that needs to be administered with. So this e-learning will address all of those issues. It's really simple to use. You can dip in and out whenever you like. So if you've only got 20 minutes that day, do the first bit and save it, then go back in and do the rest. There is an exam at the end. And one of the things it talks about is the risks and pitfalls when we use insulin. And these relate to hypoglycemia, low blood glucose, or hyperglycemia, high blood glucose, both of which can be dangerous. So our insulin safety getting it right module is free to access for all hospital trusts and community trusts. It was designed so it can be put onto your local management systems, so you can monitor your own data. It's also suitable for individuals. It's SCORM compliant, so it meets all the regulations for e-learnings and access. There's a very short learning assessment included, and if you pass that assessment, if the learner passes that assessment, they get a certificate that they can use. So if they're a nurse, that can go to towards their Nursing and Midwifery Council updates, and it can also be shown to your trusts, so you can show it and demonstrate that you've done this training. And we've undertaken to update it if any new information is required, or we will review it annually if there's no, say, particular new insulin that's out. So thank you for listening. And I'm going to hand you over to Debbie Hicks. So as you've already heard, Debbie is a very experienced nurse consultant who works in Enfield for the Medicus Health Partners. She's the national lead for Injection Techniques Matters and has presented worldwide on this. And it's my pleasure to introduce you to her.
So, thank you very much, June. And I'm going to take the next few minutes to actually talk to you about another e-learning series that we have just completed. Again, another idea that came into our heads while we were meeting one time was there's a lot of people with diabetes who reside in cared for establishments, i.e. nursing homes and care homes. So we wanted to make sure that these residents had access to the best care that they could whilst living in one of these establishments. So what we actually did was we developed a series of 4 separate modules that actually builds as a course to ensure that the staff that are caring for people with diabetes would actually have access to the most up-to-date and relevant information for this group of people. And I just want to share with you a very broad overview of these modules. And the modules follow the same process as the insulin safety module, in the fact that they last approximately 30 to 35 minutes each. They are very broad in content, and they all have an assessment at the end. And these assessments will be certificated and can be downloaded for their CPD portfolio. So I'm just wanting to take you through the modules and obviously look at the resources that accompany this content, that you as an individual can join Trend Diabetes and you can access these resources free of charge for any of your people with diabetes. So as I said, this is what we wanted to do. So we wanted to make sure that all the care homes and the nursing homes would have access to this information, and it would be available in the near future on the Skills for Health platform. And I'm going to take you through the content of each module and how you would access it, and obviously the assessment criteria. So you can see that generally people are living longer, but that means that unfortunately there's an increased incidence of people living with diabetes. And of course, the population that we're specifically looking at in this series of modules is those people in the older population. And this group of people have very complex care needs, because they don't have diabetes in isolation. They often have other comorbidities such as cardiovascular disease, heart failure, stroke, dementia, COPD, and just by definition of their age, they may well be frail too. So we wanted to be able to cover the appropriate diabetes care for this group of people with diabetes. So as I'm just giving you just a quick snapshot of where we are at the moment in the UK, because you can see here that up to 30% of people in the UK have diabetes, but these people are actually in the older age range. And you can see there's about 25% of occupants within care homes that have got diabetes. And of course, a high proportion of these people will also have dementia, which actually makes the care of somebody with diabetes much more complex when there is a cognitive disability. So Module 1 really looks at the basics of diabetes, and it looks at the common issues that face people living in care homes. It also looks at types of diabetes, signs and symptoms, and how diabetes is diagnosed. But it also looks at a very, very important part of diabetes care, which is a healthy diet. And we need to make sure these principles are embodied in the home's care, because the diet has a huge impact on blood glucose levels. But then following on from Module 1, we've got Module 2. And this looks very much at how we monitor diabetes, not just of blood glucose monitoring, but other things that we need to be monitoring for the safe care of somebody with diabetes. But it looks at the individual needs of that particular resident, because we know that people in residential care, we're not looking for tight glycemic targets like we would do in somebody who was perhaps many years younger. And we need to be aware of those targets so we keep these people safe. And then we look at the oral or non-insulin therapies that we use in people with type 2 diabetes and look at how they work and how they fit into somebody's care along with their diet and any physical activity that that person is able to do. So then we actually go on to module 3, and this talks about the safe use and administration of insulin, which I know you've heard already that June has mentioned that there is the particular module on insulin safety. But this is much more detailed. It talks about the different types of insulin and when you might use those types of insulin. It talks about the insulin action so that if staff are administering insulin to their residents, they can understand how that insulin is going to work and which insulins need to be given with food and which insulins can be given either first thing in the morning or perhaps even when the person goes to bed. But it also looks very carefully at injection technique, because June's already mentioned to you that injection technique really is much more important than people have ever given credit for. And if the technique is poor, then the insulin isn't going to work as it should do. And then in module 4, what we're actually looking at is diabetes emergencies, complications, and end-of-life care. And this is very important because this actually brings all the information in the previous 3 modules together. And what we want staff to be able to do is recognise when somebody with diabetes needs emergency care. And that could be when they're either hypoglycemic or hyperglycemic. And it's knowing when to be asking for help. And that means either medical help or even when to call 999. But also it looks at intercurrent illness and what type of increased monitoring or care is needed at that time. And then it looks at long-term complications, which unfortunately are there and potentially can affect the quality of life that someone has. And then at the end, looking at the importance of managing diabetes appropriately during the last year of life. So you can see that it's very content heavy, but it's done in such a way that it has a nice flow and the information is very well explained. So, as I mentioned earlier, and June has mentioned previously, each module has an assessment. There is 10 multiple choice questions, and this actually goes over the new learning, and that's so we can understand how much somebody is able to learn and obviously retain, because we want to make sure that this is not just a tick box exercise. And this can be retaken, but there is a bank of questions, so the questions will be changed each time somebody undertakes the assessment. And at the end of the assessment, if the pass mark is achieved, then a certificate of attendance is generated and can be easily printed off to add to their own learning portfolio. So you can see here, these are the specific resources that go along with this series of modules. And you can see here there's both information for the healthcare professional, but there's also leaflets that could be given to the individual themselves if they're able to comprehend the information, or it can be given to that individual's family. We also have lots of other information, and you can see here that this is the Trend Diabetes website, and anybody that's listening today can actually join the website free of charge. All you need to do is add your name and profession in there, and that will give you access to all of the resources that we've got on the webinar. And there's well over 20 plus different leaflets on all sorts of different areas of diabetes care. We also have webinars, we've got teaching videos, and you can also access lots of other information too. So you can access the Insulin Safety Getting It Right module through the Skills for Health organisation. And as I mentioned, the diabetes care in nursing homes is also going to be available soon. So I'd like to go back to Paul and ask, does anybody have any questions for us? And if so, please, I'm going to invite June back into the screen. We are in a bubble. We work closely together, so, and we've both been double vaccinated, so we are quite safe. But Paul, I can see there's lots of chat going on, and I'm not sure if there is any specific questions. I can see one in the Q&A box.
Yeah. So we've got one question that's coming from Lisa. It says, I have been recently informed all insulins will be prescribed via a pen device with community settings. Is that correct?
That depends on local policy. Actually, I don't have a problem with that.
The thing is that there are some insulins that unfortunately are not available in pens. So there will always be some insulins that can only be used via a needle and syringe. But what you have to remember is that we have all age ranges using insulin. So people with insulin pumps, which tends to be the new, the kind of younger age group, use vials of insulin. However, for people who are in the community, either self-injecting or being visited by a district nurse perhaps, or a carer, then you would always try to choose an insulin that was best suited to the individual. And for that reason, yes, most of the newer insulins are available in pen devices.
Thank you very much for answering that. I think there's another question just popped up in the chat. Sometimes the PT is constantly in hypo and hyper. How can we effectively adjust the doses? Okay,
so I think that it depends where the person is cared for. If the person who is administering the insulin isn't confident about adjusting the insulin, then they need to be asking advice from perhaps the person's GP, or if they're involved with a diabetes specialist nurse, because there is a lot of information that the person who is about to adjust the medication needs to consider before they would change the dose of insulin.
That's right. And the other thing is, it's always done in hindsight, really. You need hindsight. So you need to look at trends before you adjust insulin. And that's particularly pertinent on the ward setting, which is what's being discussed here. So if somebody had a blood glucose out of range at breakfast, you wouldn't change the breakfast insulin. You'd probably change the one that was given the night before, for example. So this is quite specialist in some areas, but this knowledge can be learned. So Trend Diabetes has actually got this as our next project. We're writing some materials about insulin adjustment because it is something that there's not much out there in the in leaflets and things, are there?
No.
So this is our next project. To look out for it.
Thank you for that, Debbie and June. One more question that's just come through in the chat, and then I'll go back to the Q&A panel again. And that is, from my understanding, you can only use syringe once and dispose after use, as sometimes in the ward the doctors are not available.
Okay, so I think those are two separate questions, actually. I think the second comment is actually, referring to the comment above this one. But from Lalaine, you are definitely correct. An insulin syringe and the attached needle should only be used once. Now, the disposal, if you're in a hospital, the disposal of the sharps is not a problem because every ward will have their sharps containers. But out in the community, if the person is self-administering, then they should have access to a sharps bin. And that would then be disposed of depending on the local guidelines. So, for instance, in Enfield, we have an agreement with our local council who actually collects the used sharps bins and leaves a new one in its place. That's not the same all over the country, and there is nothing like that in the actual in anywhere in Scotland. So the person who is injecting would need to find out what their local guidelines are. However, if it is a third-party injector, i.e. a nurse giving the insulin to the person with diabetes, then they should be using a safety engineered device, which means this is a syringe or a pin needle that stops the individual nurse or carer getting a needle stick injury. Now, that is part of the injection technique guidance. Again, it's on the website, but this became law in 2013, where all employers should be protecting their employees against needle stick injuries. So as an individual nurse, that person should have access to a safety engineered device when giving a third party injection.
Thank you very much. Back over to the Q&A panel. Peter has asked, are agency nurses who work with the NHS allowed to access the courses?
Yes, definitely. We do not restrict anybody having access to the resources, as long as the agency nurse actually, registers on our site or registers with you to access these, then they are more than welcome to access them.
And I think we would strongly encourage people to visit the trenddiabetes.online site and register, wouldn't we, to be able to gather as much information as they can.
Yes.
Another question that's...
Sorry, the e-learnings won't be on there, just the written resources. Just to be
absolutely. Another question that's coming from Gail, and I see she's got a follow-up question. Regarding diet control diabetes in care/nursing homes and who have HbA1c completed by their GPs, should some level of blood glucose monitoring still occur, like a random blood glucose?
No, not really, not unless the person's unwell. If the person has got, say, a urinary tract infection or an infective illness, it's worth doing a blood glucose, a capillary blood glucose. But otherwise, people who are only treated with diet alone, because they should all be treated with diet, But if they're only on diet alone, they wouldn't need regular blood glucose monitoring. The HbA1c is sufficient.
Oh, Paul, you're on mute.
Oh, it had to happen at some point. Also, Gail followed up with what's the guidelines on calibration of blood glucose monitors in care or / nursing homes?
Okay, so this is actually well documented in the MHRA website. So, for instance, if a home is using a blood glucose monitor to change levels of medication or to monitor people with diabetes, then they should be making sure that they are undertaking both internal quality assurance checks and external quality assurance checks. The internal quality assurance check should be taken on a daily basis, and that's to make sure that the machine is actually ready and calibrated and is accurate for a test to be done during that day. Now, if it's not used on a daily basis, then obviously it would need to be checked at least weekly to make sure that people are maintaining their competence in using the machine. However, and a record of that result each time should be documented. Equally, there is an external quality control check, which is a blind sample of glucose that is sent to the home, and the home would delegate the testing to somebody who would then send the result to the provider of the external quality assurance, and they would map that against the actual sample result. And that's protecting the person using the meter. But these are essential because if at any point there was any kind of altercation, maybe somebody was to be harmed in any way, the first thing that would be checked was, is there any quality assurance on the technology that's been used to care for this individual? So it's imperative that any care home that's using a blood glucose meter actually checks this, because again, this is important, and it would be something that the CQC would be looking at as well.
Thank you. Debbie, did you want to follow up? June?
Yeah, June so can share that.
There's a couple of questions here. So how do you arrange for external quality control in a GP surgery? There's organisations that do it. Your hospital trust will have contracts with people that do it.
I can actually tell you what happens in Enfield, because the 26 practices that I work with, we have got a policy for both external and internal quality assurance. And for us, we use the GlucoRx HCT meter, which checks both the blood glucose and blood ketones, which is that's what kind of meter you need. And you obviously, as an establishment, would buy the strips that would be used in the machine. However, the company provide the machine and the quality assurance scheme free of charge. So if you are looking for a quality assurance scheme, then you might look to your local diabetes team that would be able to put you in touch with somebody that would be able to help on this particular aspect of care.
So there's a couple of questions I was just going to answer. There's one from Alison that's still on the chat line about a safe insulin prescription, and I don't want to miss it. So you can have a safe insulin prescription handwritten or electronically, but you need to make sure that all the information is provided. So you need to make sure it's for the right person for a start, and the date of birth should be written. So the name should be written in full and the date of birth. The insulin product itself needs to be the correct one for that individual, and many of them have similar names. And the device that's going to be used to administer that insulin, if it's a pen device, needs to be named. So, and it needs to be signed. So there's quite a few steps, and it's showing in our e-learning module. You'll be able to see some of that. So there's also something from Lisa on the chat line. So we're a quick Q&A. So we're going from one to another. So the Q&A says, are pen devices safe to use when you're given a third-party injection? And absolutely they are safe to use. I mean, it's actually more dangerous to try and draw up an insulin from a pen device into a syringe and then administer it with the syringe, because you're probably not going to get the right dose. So it's absolutely safe, and please don't be anxious. Some insulins only come in pen devices. We don't want people drawing up insulin out of them.
But it's really important that, you know, all of those getting it right sections are actually considered for each individual, because it states getting the device right. So you have to check that the device fits the insulin, because we do have different pens. So we have reusable pens that have cartridges that are inserted into them, and we've got preloaded or disposable pens that are already filled with the insulin as prescribed. But there are different manufacturers of insulin that produce different pens. So again, it's covered in the insulin safety module that you shouldn't try and, for example, fit a Lilly cartridge into a Novo Nordisk pen, because they're not meant to go together, and neither company will guarantee that efficacy with the wrong cartridge in the pen. So it's really important to think of all these different things, and that's why in the e-learning module it's very, you know, succinctly set out as to what things you need to consider.
So there's a question from Lena, which I think, Lena, you must be impatient, I think, because you've said about if the blood glucose shows high, and can you give a nat rapid bolus, which is a fast-acting insulin? It has to be prescribed, of course. If somebody's blood glucose is showing high on the meter, you need to think, why is that happening? So is it because that person's unwell? And if they're unwell, you need to test for ketones as well. Is it because the previous 2 doses of insulin haven't been given, or 1 dose of insulin hasn't been given? So you need to think about that. And if it happens on more than one occasion, you really want somebody to come and review that individual to see why their readings are reading high and whether they need to have their insulin adjusted. So we wouldn't want to be seeing high on the meter over a period of a couple of days or a day even. Want to know why it's happening.
But equally, Lena, it could be that the person hasn't washed their hands before having the test done, and things that we touch can affect the accuracy of the test. So if somebody had been eating an orange or a tangerine, something like that, then that could definitely put the blood glucose level up, as would anything that was sweet. So, you know, you always need to follow the manufacturer's instructions when you're doing a glucose test.
And this has happened in hospital where there was a death, where the person had intravenous dextrose running in their drip, and it leaked, so it was on the individual's hands and the hand wasn't washed. So they gave massive doses of insulin, or big doses of insulin, to cover it, but actually it was something on the finger.
So just before we wrap up today, there's one more question I think we can just squeeze in from Emily. Emily writes, I work in A&E and often patients do not bring their insulin with them, so it has to be ordered from pharmacy. meaning hours sometimes pass before it arrives. Is it advisable to give it as soon as it arrives or wait for the next dose? I'm aware it must depend on the type of insulin and how long acting it is.
Well, quite honestly, you need to look at what the action of that insulin is. So if it's a pre-mixed insulin, you haven't got that particular brand because you're waiting for it, but you've got some more in the department, you could give the other one. So you wouldn't want to do it often, but if you were going to wait hours for an insulin to come, no, it's not safe to keep people waiting. I've seen people come in and be sitting waiting on a hospital ward for 4 hours for their insulin with type 1 diabetes, and by then the blood glucose is sky high and they're developing ketoacidosis. So some insulin needs to be given, and the medics need to decide, or the diabetes specialist nurses need to decide what you can give in the interim, but something needs to be given. I hope that helps.
Well,
one of the questions just quickly that I did answer actually in the Q&A box, but it is worth just mentioning that somebody asked about should a sliding scale be used in somebody who is not managing their diet very well. Well, a sliding scale should actually only be used when somebody is not eating. By sliding scale, we mean a
intravenous
insulin. But a sliding scale, as I think perhaps the question was maybe a sliding scale with somebody who is having insulin injections by maybe a third party. And the problem, as June already mentioned, is you've got to look backwards when you're giving insulin to know what dose needs to be adjusted. If you change the dose in a person who's not carbohydrate counting on a frequent basis, you will never gain good glycemic control because you are actually changing the dose after the event. So we would always advise that insulin doses, unless the person is carbohydrate counting, that you look for trends and you look for patterns over 3 days and then adjust, as opposed to jumping in and giving more insulin.
Well, thank you very much for your answers, and thank you very much for posting the questions from all our participants today. Well, we're nearly out of time, so I'd just like to take the opportunity to thank June and Debbie for taking the time to talk with us today. Here at Skills for Health, we're very proud to be a small part of this journey in being able to offer the Insulin Safety Getting It Right course as part of our content portfolio. And it's been great to have the time to reflect on the insights into insulin error in both hospitals and the community, and the importance of promoting safety when providing diabetes care for people with diabetes. Just to go back over the way to access this course. So the course is free at an organizational level. So you'll need to be getting in touch with your learning and development team to ask them to come and talk to us. We'll then be able to provide it free into the learning system the organization provides. This is simply because it's easier to do at that size of scale and to make the course available to everyone, which of course is, the intention is to be able to get it to as many people as possible. If you do need to access it as an individual, then again, the opportunity is there to come and purchase it for a small cost from the Skills platform, and the links will be made available to you for that. And again, this is just because we have to provide a system to deliver the content to you. So it's just a small charge which covers the internal costs for enabling us to do that. So again, I'd just like to thank you all for taking the time to join this webinar today and for your questions and comments over the past 60 minutes. And I hope that we've given you a good insight into the topic. So thanks again to June and Debbie, and that's it for today.
Bye.